My name is John Sproul, and I am Senior Policy Director at the Institute of Health Economics, and welcome to this lecture. And following that, a number of you are going to be participating in a workshop. We're very pleased to be able to have as our guest on this lovely morning Dr. Carl May, who is with the London School of Hygiene and Tropical Medicine. Formerly, for a long time, was at the University of Southampton. And we're so thrilled that he and his colleague Tracy Finch are able to come and share the learnings to the workshop today. Dr. May is a true leading expert in implementation science and is a medical sociologist by training, and we're very pleased he's be able to come here and share his learnings and insights in Alberta. So I'll pass over to Dr. May.
Thank you so much. Thank you. Well, good morning, everybody. I am Carl May, and I'm delighted to be here and very grateful for the invitation. And very grateful to Hannah Price out there, who has made all of the arrangements to make this happen, and for Chris McCabe, who's made great efforts to get us here. So thank you very much, and thank you all for turning out this morning to hear what I'm going to say. See if I can break something now. It's traditional that I break something. So what am I going to do this morning? I am going to learn how to use that keyboard. So I'm going to do 4 things. I'm going to start by asking what implementation science is. And I've already been talking about this with a couple of people who are here this morning. I'm going to talk about how implementation processes are embedded or part of complex adaptive systems. And I don't know why I wrote, is there a division between science and the real world? I think I was feeling unnecessarily philosophical at that point. I will try to say something about that. And then I'm going to ask, how important is collective action? And for the 2 or 3 people here who've read anything that I've written or that Tracy and I have written, you'll know that we do think it is quite important. So we think about, I've got a thing I can use. I don't need to keep going back and doing that. Right, so let's start with the idea of what is implementation science. What are we here to think about this morning? And there is a thing about how do we define a field of research and development in a way that is useful to people in practice, which is the kind of audience that we all hope that our work supports and assists, and to people who are researchers. And implementation science as a field is a funny thing, and it's not as easy to define as one might think. So very fortunately, the National Institutes of Health in the US have developed this very clear definition, and I'm going to work my way through the components of this definition. Definitions are everything in science, and they're often rather less important in practice, but where we are in implementation science means that we need to be defining our terms with precision and clarity. So, what do the National Institutes of Health say that implementation science is? Well, the way that I'm seeing all of this is that people are characterizing implementation science not as a set of questions, but actually as a kind of methodology, as a way of thinking about doing rather than thinking about the content of things. And so here, Implementation science is the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve our impact on population health. So it's about translation. It's about translating knowledge into practice. And it's kind of configured there in a whole range of other practices and other fields of work. So we could go, for example, I was at a meeting in Vienna a couple of years ago about prevention science, which is the science of stopping people doing things that they find very attractive, like drinking and snorting coke and, you know, dancing for hours at raves. So there's a whole discipline that's aimed at making life miserable and unbearable. It's always worth thinking about those people. Of course, those aren't the things that they're doing. But there are sciences of everything now. There are sciences of implementation. There are sciences of prevention. There are sciences of improvement. There are sciences of safety. And so we need to start thinking about what we mean by science. So there was a fantastic physicist called John Zeeman. And let's start with his simple definition. So science, he says, is the rational production and application of knowledge, and then in brackets, theories, and technique, and then in brackets, practices, according to replicable procedures, to make observations, predictions, and discoveries. And in doing so, to make a cumulative understanding of the phenomenal world. Science is one of the mechanisms by which we comprehend the shared realities of our place in the cosmos and make it meaningful. Well, that's quite a responsibility, I guess. No pressure. So when we're thinking about implementation science, we're thinking about how do we conceive of these acts of translation, translation of evidence into practice. But that's not all. It's not all that we're thinking about as we do implementation. So it's a methodology for other things as well. And so here we've got NIH saying, this discipline is characterized by a variety of research designs and methodological approaches, partnerships with key stakeholder groups, and those are patients, providers, organizations, systems, and communities. So it's about getting people on board and rolling them into what looks like a social movement to me, as a sociologist, and a political movement too, about saying we need to be more rational in the world. We need to make better decisions that are founded on robust knowledge and rigorous research. Well, I don't know whether anybody's noticed, but by and large, politicians and policymakers are hugely enthusiastic about making rational, sensible decisions. And in my own country, they seem to have devoted the last 3 years to an immense act of rational behaviour and common sense. And oh, it's been so impressive to watch. I've hardly been able to contain myself as I've watched them translating robust, rigorous knowledge into sensible practices. I don't know, really. You know, where are we all going to end up? I can't begin to think. So, but it is about rolling things in together and attracting and making a community or set of communities of practice. So implementation science then is a methodology of participation as well as a methodology of translation. It's about bringing people and things together. Oh, and these methods carry things from one place to the other. And they carry knowledge about practice into practice. But, you know, So routine healthcare and public health settings to improve our impact on population health, and developing and testing ways to effectively and efficiently integrate evidence-based practices, interventions, and policies into routine health settings. Well, this is really important, because one of the things that implementation science does is it begins with abstract knowledge. It begins with quantitative knowledge, statistical knowledge about what's effective and what's good. And what's effective is not always what is good, and vice versa. So what implementation science does is it carries that knowledge into practice. And that's a remarkable achievement when it works. And finally, and this is the bit I like, it's a methodology of action. It's about, so I must apologize, when I was writing these slides, I thought that they would be up there rather than down there. So I was thinking about a different kind of room, but the implementation scientists are in the business of designing methods of causing action. You know, the big question, the question that we're going to be kind of looking at a bit in a minute, is about whether those actions are about individual behavior change or some kind of collective set of practices, whether we can distinguish between those two things even in a meaningful way. You know, I quite like the differentiation between change management and individual behavior change, because it sort of makes it sound as though there really is a big difference. But we live in a world made of individuals, and those individuals live in a world made of collectives. So the differences may not be quite as powerful as one might think. So we've got essentially four kinds of methodologies at work: translation, transportation, participation, and action. And those are the effects that that implementation science has. Implementation science is a kind of work. We do work to make things happen. And because I'm a sociologist as well as an implementation scientist, I kind of start looking at what we're doing as well as what they're doing, and asking myself, well, how does that work? What's really going on here? So we want our world to be more rational, and we want things to be more effective. And the last thing that we want, to be honest, if you're a patient in a hospital, is to be getting suboptimal or substandard or unsafe care. Having been on the end of a big medical accident a couple of years ago, I feel really quite strongly about this. So we've got implementation science as a set of methodologies. And what do implementation scientists do? Well, they're involved in a massive exercise of alliteration. They seek a scientific method to implement the results of good science. What could be better than that? And if I'm beginning to sound a bit like Joyce Meyer or somebody like that, it's because I really have this sense that what we're doing in this sort of proto-discipline is a good thing. And the question is, how should we understand what we're doing? And if we can understand what we're doing more effectively, then we can make what we're doing better. Of course, there is that little bit of the sociologist in me that wants to do a big critique here. I'll leave that for another day. So let's think about the next thing that's going on here. We have all of these methods of translating and transporting and participating and acting around the things that Canada is actually very famous for: knowledge translation, knowledge transfer. Huge programs of work for many years in this country aimed at that. And some really important work done in this city by people like Carol Estabrooks in nursing and others. So we've got these very exciting, rational practices that are going to make the world a better place. And maybe the thing that we need to think about a little bit is what confounds those processes. And so we've got this thing here, we've got context and complexity. These are areas that have attracted enormous interest of late as people in implementation science have caught up with the idea that it is not enough to have a really good intervention design. And that really good intervention designs so often fail because they don't account for either the context in which they're operating, and we'll do some work about what a context is in a minute, or the complexity of the environment that they're working in. And we'll talk about that again in a second. So in this context, we can make the division. We have two real ways of understanding implementation interventions. So one is about the application of behavior change techniques that are focused on individuals, and the other is about the effective transformation of practices and systems through implementation models that are focused on collectives, different kinds, whether those are groups or networks or diffusion processes or however we conceive of those. So this is the central division in the field. It's a sociological observation of mine that my medical colleagues really like individual change models because they're taught to deal and to focus on individual cases as students. And individual behavior is so much more easily measured than group behavior. It's, there is a vast industry devoted to the construction of measures of individual behavior change and attitudes and intentions, and really, you need wings to fly above it. You really do. But what's important to say about all of this is that in both of these fields, the scholarship is just outstanding. Really brilliant scholarship. And it's a privilege to kind of be a minor player in some of that work. So we have, research that focuses on knowledge translation and mobilization. It's often anchored in social cognitive theory and psychology. And we have research that's concerned with people in context, that's anchored in dynamical approaches to collective action or group processes, however we want to think about it. And these often use very different methods. They often have very different theoretical foundations. But they face a common set of problems. And here are 4 of them. If we're trying to implement some evidence-based intervention, we face 4. So first of all, we face the problem of complicatedness, which is in any social system, in any context for healthcare, there are a huge number of interdependent moving parts. A frightening number. One of the tasks that I set my master's students when I teach methods is to go into a cafe and watch the baristas making coffee and serving it. because it looks like a really simple process. But you can probably identify about 300 different activities that are involved in just serving a cup of coffee and interacting with the person who wants it. It's an incredibly, it's just an extraordinarily intricate set of interactions and tasks. So when we start thinking about whether people should have total bowel resection or local excision with an early tumour, then we start to look at sets of practices which number in the tens of thousands. Right? Quite extraordinary. So then we have the more general problem of complexity, which is emergence, a dynamical emergence over time and across space. Social time and social space. And as anybody who's ever sat in a lecture where I'm talking, time proceeds at different speeds for different people. So this is going very quickly for me, but some of you are probably suicidal now at this stage, having had to listen to me witter on for what seems like days. So we distinguish between, if you like, astronomical time and social time. We experience time and space differently, you know. So John is far, far away from me, and I am possibly too close and too dull for him. So we've got all of this stuff that's going on about just the sheer volume of activities in any setting, and the fact that it's dynamic and it's emergent. And so what does those mean? They mean that actually the outcomes of those processes may be unpredictable. You know, I shan't hazard a guess about how this might become unpredictable, but there is a thing here about unpredictability, uncertainty about both performance and outcome. And volatility. So volatility is important. We believe that we live in a world of equilibrium, or you would if you didn't live in England. But those equilibrium states are always punctuated by different kinds of dynamical change. And some of those changes are very rapid. Very, very rapid. So what that means is that whenever we're thinking about intervention design, we need to think too about the complex social systems in which it is embedded, which we embed those designs. And this is the big dilemma for the implementation scientist. How to design a rigorous, well thought through and predictable intervention that works in a dynamical, complex, volatile, and unpredictable environment. This is a tremendously difficult problem to solve. Well, fortunately, I don't have to solve it. I merely have to critique it. That's not strictly true. I do have to solve these things sometimes. And this is why thinking about implementation science as methodology helps us, because it takes our attention away from the very specific mechanics of research design and asks us to think about what it is precisely that we want to achieve. And that's not always done. I struggle with the kind of the immense density of clinical trials in implementation science. Huge numbers of trials. And my colleague Tracy Finch and I are involved in a huge set of trials in Europe looking at the implementation of cognitive behavioural therapy by means of telemedicine systems. And we just have this really interesting thing where you've got very rigorous research designs that are interacting in very complex ways with their environment and being shaped and changed by their environment. So although we think about trials as being immutable and rigid and inflexible in their design, they're constantly being made different by the environment that they're set in. The meanings of things change. Activities change. Roles are different between settings, and they change over time. Which always makes me a little bit kind of wary of thinking about trials as the gold standard. You know, they're a gold standard. So here we have, you know, implementation science depends on methodological rigor. We just need to think about what methodologies we're being rigorous about. And there are so many different ways of understanding conflict, and this is a big list with lots of words. Please don't take too much notice of it, but it divides up into 3 different kinds of ways of understanding context: places, people, and systems. But I kind of think that we need to rethink context, not as an organisational structure or the structure of a population, but actually to think about it in terms of process ecology, the way that people think about the migration of whales, you know, things that are happening, that are processes in time and space that shape a physical environment or shape a social environment. Now, I quite like the idea of process ecologies. I mean, in part because it recognises that our behaviour is environmentally formed as well as informed by our own agency and our own ideas. Very exciting kind of way of thinking about it. And then the lovely Jeffrey Braithwaite, who actually may be watching us in Australia. Hi. And also, hello, Mum. Has this fantastic definition of a complex adaptive system. It takes great work, very, very very complex work that's derived from, again, ecological mathematics, and says we need to think about the world in which we work and live in those ways, and to ask ourselves about the irreducible nature of the phenomena that we're concerned with. So all of those bits of stuff that I were talking about, understanding what they do, requires us to think of them as a whole as well as individual components. Okay? And he says, and he's absolutely right, this makes it difficult to plan, execute, and then predict how an intervention will be adopted and taken up in any specific setting. He also makes the point that no other industry has the equivalent range and depth, such intricate funding models, and the multiple moving parts and the complicated clients with diverse needs. And I think that's true, although remember, this is a man who's never tried to travel by train in the United Kingdom, where all of those things apply in spades. We can't simply understand an intervention by knowing about the individual components, and that has real implications, doesn't it, if you are doing implementation trials, where we have a program theory about how the components of an intervention will work in context. It means that the outcomes of those are unpredictable. And they come, as Jeffrey Braithwaite's team says, they manifest on multiple levels. They're interwoven, they're interlinked. And those interweavings and interlinkings change over time. They're not stable. So implementation science struggles with complexity. But actually, all of the health sciences struggle with complexity. This isn't something that we face alone. Epidemiology struggles with complexity. Personalized stratified medicine struggles with complexity. The question is, how should we think about that? So I think, here we are at part 3 of my talk. And does it have to be either or? In terms of methods, in terms of activities, and in terms of ways of conceiving implementation processes. Well, I tell you what I think. One of the reasons that I love doing implementation work is because implementation science takes us to incredibly fundamental questions about human behavior and the organization of human societies. So for me as a sociologist, it gives me a way of doing both basic and applied research in the same grant, which isn't a bad place to be, I think. Here's an overhead that when you read it to yourself actually makes no sense, so we'll just move on very swiftly from that. I don't know quite what I was thinking when I wrote that. We'll move to something else. So when we're thinking about how to understand implementation processes, and when we're thinking about whether we're looking at change management or individual behavior change, we're struggling in part not simply with the business of complexity, but also with something that humans are fantastically good at doing, which is managing and organizing complex adaptive systems. We're fantastically good at that. We create these systems and then we shape them and we shape our behavior within them. If, for example, I don't know, I look at the woods and I think, are there bears there? Probably not. But bears, by and large, aren't dealing very much with complex adaptive systems. They're looking for fruit. So they do experience complexity, but I'm sure that bears think about it differently. They think, where's the fruit? Or how am I going to get into that car? That's the other thing. I'm astonished to discover that bears in California actually move into people's houses when they go on vacation. These are clever creatures. Anyway, let's think about how we do that, and let's start with thinking about, at a macro level, what mechanisms do we employ as actors to make implementation processes work, to make the field in which we work. So the first one is obviously we exercise power. We exercise power over each other, and we do a lot of work to persuade. And sometimes that persuasion is really interesting and really powerful. So I have a really great postdoc who has done a fantastic systematic review of physical activity for people who have survived cancer. And one of the things that we noticed as we did that, or she did that, was that there was always quite a big effect in the control group. Well, where did that come from? It probably came from them reading the informed consent and thinking, oh, I'll do a bit of that. That might be good for me. And so effects in control groups, persuasion and power. And we don't need to think of power as an oppressive thing or as a force. Power is very productive and creative too. And then we can define, if we're thinking about it in this way, we can actually define implementation and implementation science differently. And we can say an implementation process is put in train when a coalition of actors seek to translate their strategic intentions into the everyday practices of others. And that's what an implementation process is. It's a relationship between two groups of people, one of whom wants us to do something, and the other is going to either do or not do, or somewhere in between. I like that. It's a simple explanation, and it's a social explanation. It doesn't say anything about evidence. It says here are some activities: doing and being strategic. And we can then think about, well, what do people do when they're faced with that kind of work? Because this is all work, incidentally. These are the things that we do. This is about action. We have self-organizing mechanisms. Going back to what I was saying about complexity, humans do lots of self-organization. We have big self-organizing mechanisms, self-writing mechanisms, and that make adaptation possible in complex adaptive systems. And a couple of years ago, Tracy and I and one of our colleagues, Mark Johnson, wrote a paper where we just pointed to the ways in which, although we think a lot about complex adaptive systems, we focus on complexity, not adaptation. And it's actually the work of adaptation that's the really important thing in a complex adaptive system. It's really important. So implementation processes are motivated and shaped by those self-organizing mechanisms. And we have constraint and control. So implementation processes represent dynamical features of human agency under conditions of constraint. We regulate our actions, and we regulate the actions of others. You know? And then the bit that I love, performative action. Implementation processes are realized when the ensembles of practices, remember that there is no single thing in an intervention, there are lots of bits of it, and they work together as an ensemble, are embedded in the life world, so they become part of our world. Now, I'm just going to run this back because quite by accident I've got a model of how the 2008 financial crash worked. Okay? So a coalition of actors sought to translate their strategic intentions into the everyday practices of others. They deregulated the financial market, they eliminated the Bretton Woods Agreement, the banks began to cooperate to generate extraordinary environments in which they could accumulate and circulate money in a way that nobody had ever done before. They flooded their worlds with adaptive innovation. They invented bizarre new products that nobody understood and that nobody could work with, but which generated enormous sums of money, quite remarkable sums of money. And nobody really understood why. For those of you who've ever watched the film The Big Short, has anybody here seen The Big Short? Yeah. It's a film about how nobody understands what they're doing. And everybody's really enjoying it. They're really enjoying the benefits of not understanding what's going on because they can't see where it's going to take them. There are constraints and controls. There are conditions of constraint, but actually they're overwhelmed by the adaptive innovations. They're overwhelmed by derivatives and extraordinary kind of worthless piles of mortgages that everybody believes are a thing. I mean, I maybe shouldn't be saying this in a room full of economists, but you never know. Oh. And then there's all of that action. People are selling it, they're banking it, they're doing the stuff, and then suddenly it all comes to pieces. There's so much adaptation in the system, there's so much innovation in the system that it floods it and it becomes uncontrollable. And suddenly performative actions become completely destabilized. Now, this happens in a lot of different environments. It happens in healthcare systems, but the 2008 financial crash is a fantastic, dramatic example of what happens when the translation of strategic intentions into everyday practices involves constraint and adaptation getting out of balance, getting out of sync. And that's why it's interesting to see in the British National Health Service, I think there are about 146 different agencies that seek to regulate the work of 153 NHS trusts. You know, the possibilities of adaptive innovation in an environment like that are powerfully constrained. You know, that's true in the VA in the US as well. You know, there are so many agencies that exercise constraint and control, either in a real way or simply by their existence. So sometimes we self-censor our activity. And in England, there's a test that some NHS managers apply, which is, what would it look like on the front page of the Daily Mail? Okay? And that's a good test. If it would look bad on the front page of the Daily Mail, you probably don't want to do it. But there are plenty of real agencies that are at work there as well. So we have all of these very, very kind of complex but interesting sets of mechanisms and activities. And what I'm trying to do here is to make a case for implementation science as being about the practice of translation of strategic intentions into everyday practices. But we need to think about what it is that we're actually looking at being implemented. And it'll not surprise you to know that I've got an idea about that. When we do big trials, we focus on intervention components. We focus on the things that we want to measure and implement. So it's really important to think that actually those things change the world in which they're set. So they change the interaction strategies of people, and they change their assumed capabilities, the things that they can do. They change the roles and resources, the norms and roles that people have, and they change their accountabilities. And somewhere in here, they change the organizing logic of things. And if we want to think about a changed logic, over the past 40 years, people with chronic diseases or long-term conditions have been gradually re-logicked so that they're in charge of their own condition. In the 1950s, if you had diabetes, nobody was going to put you in charge of your condition. No one. Because if they did, you'd die. Because all of those drugs were not available. But as those conditions have become long-term and in some way manageable, then the organizing logic of practice has changed. And those conditions have been given back to the people who have them to manage them. You know, very interesting to watch that happening. You know, in the UK and in some other countries, there are other shifts in the organizing logic of healthcare around changing patterns of financial responsibility, changing patterns of political responsibility. But these are sets of socially kind of mediated agreements and values that give cognitive authority to actors in the system. They make them into people who might have their own strategic intentions. And so they introduce different kinds of conflict. And that, I think, is the most interesting thing. Right. Oh, broken it. So as I'm sort of coming to the conclusion of my talk, perhaps not quickly enough, but I am heading in that direction. I'm going to go back to 2009, which was the year of the case for collective action in implementation science. I and others had been doing ethnographic studies of clinical trials and implementation processes around different kinds of new technologies. My colleague Tracy Finch, who's sitting at the front, was a big part of that. And this Friday, we celebrate our 20th anniversary as collaborators and co-investigators, which is, you know, as she put it while we were having breakfast, some people don't get married for that long. But here's the thing. Through these 3 papers, so Tracy and I published a paper about normalization process theory, which is a theory of collective action in implementation. Brian Weiner published a social psychological theory of organizational readiness for change, which is a theoretical model that draws on a perspective of change as a set of collective and collaborative arrangements. And the extraordinary Laura Damschroeder and her colleagues published the CIFA, the Consolidated Framework for Implementation Research. And in fact, all of these papers came out in the same month. It was quite extraordinary. And it was a kind of resurgence of a view that we needed to understand how people worked together rather than, or in addition to, perhaps, how they work as individuals to achieve implementation outcomes. And understanding that problem in that way means that we can apprehend context and complexity as part of the problem, as part of the system. We didn't quite realise that then, but that's how it's turned out. And when we analyse implementation as collective action, we're looking at 3 things. So here we've got, this is from some work I've done about e-health systems. We're enacting components. Well, I've already said, you know, when we enact components, we're actually interacting with a complex system. And implementation is about adaptive work in that system. Embedding. We routinely incorporate things in that system, in our practice, in our everyday lives. A great example of this, incidentally, is PowerPoint. Once upon a time, if I wanted to give a talk, I'd do it like this. It's great to be in Edmonton, and I'm very grateful to Chris McCabe and colleagues for the invitation to give not only this talk. And that would go on for about an hour and a half. And the oxygen would disappear from the room. People would be in tears. They'd be collapsed and everything. But suddenly, this new technology called PowerPoint appeared. And remember, it was designed for people to give sales talks. And it changed the character of these kinds of interactions. It changed my role as the speaker. So now, suddenly, I'm not actually reading to you from a script, from a talk. I'm mediating between you and the screen. And it's the screen that becomes the object of record in a talk like this, not me. I become a bit part player in my own PowerPoint presentation. And at one time, I'd kind of play to that by having lots of cartoons from the New Yorker in my PowerPoint presentations, and those started to appear on the web. And after a while, I got a cease and desist letter from Condé Nast, which suggested that if that carried on, I was going to spend 5 years in the company of a member of the Aryan nation called Raoul in a federal pen. And so I eliminated all of those slides from my presentations. But that's a great implementation process that we never noticed happening. We never noticed that happening. You know, One day I was using acetate slides and an overhead projector that would regularly catch fire, to the amusement of my students and the excitement of people in the laboratories upstairs who'd have to evacuate when the smoke alarms went off. So there's all of this stuff that we don't notice, but it's completely changed the social dynamics of these interactions. Some of you, obviously many of you, are so young that this is your normal life. But once upon a time, people did actually just get up and talk. And so in all of this, I and Tracy and others have developed a theoretical model of implementation processes, which we've called normalization process theory. And I think it would be fair to say that the success of this has shocked and astonished me. Because by and large, sociological theories don't catch on. But I think we've just passed 400 studies that have been organised around NPT, or 400 reports of protocols, studies, and systematic reviews. And so what we're interested in doing is actually kind of understanding the mechanisms that promote and inhibit implementation. So these are the mechanisms by which we do the work of implementation, and we do the work of adaptation to context. You know, because we're interested in how things become part of our world, how they become integrated in practice. Why have a theory? You know, why not just have a model or a framework? Well, theories are useful because they're explanations. Right? They identify and characterize and explain dynamic and emergent phenomena. And theories are useful tools. I think Kurt Lewin, the psychologist, is reputed to have said, you know, there's nothing so practical as a good theory. And for most of us, I think that's true. You know, our lives are organised around theories, whether we know it or not. Anybody in this room who's ever talked about depression has actually interrogated a theory, and a new one at that, because depression didn't really exist before the 1950s. And it existed because a chemist, a pharmaceutical chemist, was really, and this is true, investigating rocket fuel. Incredible. So this is the world that we live in. It's complex, and you know, it seems inchoate and difficult to understand. And this is what theories try to do, is they try to identify and simplify processes and actions and meanings in a way that makes them usable by people. So NPT, Normalization Process Theory, specifies 4 kinds of mechanisms. The work that we do to understand and organize and to make components of a complex intervention. The work that defines and organizes people. The work that defines and organizes action. And the work that defines and organizes appraisal and reconfiguration of action. So those are 4 fundamental mechanisms at work: coherence, cognitive participation, collective action, and reflexive monitoring. They're very powerful. We can see them at work everywhere. Has anybody here ever written a scientific paper? Yeah? Oh, come on. Who's written a scientific paper? I have. I'll own up to it. Okay? You've just performed a major act of reflexive monitoring. So we're doing this thing, we're trying to understand the core self-organizing mechanisms in these processes, the core things that make them happen. And we can do that in two ways. We can do them by measuring activity, and Tracy and her colleagues have developed a series of instruments to do that. And some of you who are participating in the workshop that we're doing over the next couple of days will encounter those. But we can also do them by ethnographic observation and simple participation. You can also understand them in those ways. And since I've been talking at great length about unpredictability and complexity and complicatedness, you'll appreciate that I've just laid it out as a set of boxes and arrows. When I was a little boy, my father was a clerk of works, and our house was full of the Architect's Journal. And at a time when mid-century modern was really big, and there were lots of straight lines in the world as an architectural style. And I became very enamored, I think, as a little boy with boxes and arrows, and I've never been able to shake it. When we think about all of the stuff that I've been talking about, we're actually thinking about a set of feedback loops. Coherence, participation, action, monitoring. And what do those create? They create workability and integration. Or they don't. Or they don't create those things, and implementation fails. Because these are ways in which we fight complexity, as well as adapt to it. So, my kind of final sort of final approach to the end is, if we're thinking about implementation science, let's think about it as a science of collaborative work, as a science of people working together to achieve particular kinds of objectives. Collaborative work is, as we all know, where it's at. It's where the action is. It's how people interact and change things. So, what have I tried to do today? So I've tried to show how implementation science is often constructed as a methodology or as a set of methodologies that do translation and transportation and participation and action. I've said that when we do implementation science, we're interested in how implementation processes are part of, they're embedded in complex adaptive systems. And I've said that by using simple frameworks, we can make concrete links between the practice of science and the practices of behavior change and change management. And finally, I've said that what implementation science consistently reveals is the importance of collective action and collaborative work. And that implementation science could be the science of collaborative work. So thank you all very much for your kind attention and your patience. That's kind of where I stand on the field that I work in and the field that some of you work in too. Thank you.
Thanks very much, Carl. And we have a bit of time for some questions from the audience. And a couple of people, I'll hand this around so that actually people online can hear. This doesn't amplify, actually. It'll just be so that if we're recording. And there were a couple of questions from online, so I might just start with one, and then people can put on their signs. And can the speaker recommend any further reading on process ecology in the context of implementation science? You mentioned process ecology, and it sparked some interest from people of other references that they might be able to have.
Not really, because I made it up last night. But there will be a paper about it at some point in the next year. I was trying to think how to describe what I was interested in, and I've been reading. I'm ashamed to sort of put it this way. I had been reading a book about dinosaurs, and the dinosaur trackways that run along the edge of the Rockies between here and, well, not here, but over there, and the southern United States, and sort of thinking about dinosaurs that migrated up and down the coast, and sort of thinking about that they would move through different kinds of ecology, but as they did so, they created one, and we can see the kinds of traces of that, 90 million years later, in their trackways and footprints and where they have died and laid. So so there will be something, but just not yet.
Are there any questions? I have a second one. Someone just asked, I think it was about a complex adaptive system, and they asked a question about the re-logic of diseases. I don't know if that makes any particular sense, but I guess it would be actually that how one kind of deals with quite dynamic changes in kind of new knowledge. I don't know if you can interpret what re-logic is.
Well, I tell you what, I'm just going to make it mean what I want it to mean. But here's the thing. My guess is that when we think about complex adaptive systems, we often overthink complexity and underthink adaptation. And when we overthink complexity, we become paralyzed because the world is so difficult, and we don't know what's going to happen, and we don't know whether what we do will do any good. But actually, humans are pretty good at working out what will work and what will do good. And when we think about complexity, we often mistake complexity for chaos. And so we think that the systems that we're addressing are chaotic, that the unpredictability is, and the great example of this is me making a cup of tea in London, and that the steam coming from the pot has a series of effects that lead to the utter destruction of a tropical island in the Pacific in a tropical storm. And so we sort of think, those unpredictable consequences are chaotic. No. Unpredictable consequences are unpredictable. But they reveal themselves, and they are made manifest over time. A great example of this is the terrible epidemic of HIV in the 1980s. And in different places, different kinds of state action or government action intervened in different ways to control that epidemic. And that epidemic was non-linear. It was, in some ways, hard to understand, because the kind of pathogenesis of the disease was actually hard to understand for a while. And two things happened. The first of all, as a species, we did a massive amount of adaptation work, and we implemented lots of measures to control it, and some of which were politically extremely contentious, others which were clinically contentious at the time. And as we did that, the disease itself began to modify itself. Because one of the things that we know from the extraordinary epidemic of venereal disease in the 16th century is diseases that kill very quickly soon die out, because they destroy their hosts, and they can't, the pathogen can't reproduce itself. That's what happened with Spanish flu in the 1920s, 1919, 1920s. Or as it's called in Spain, the English disease. there are those things. We adapt and we change the environment that we're working in. I have no idea whether that will satisfy the questioner.
Just one quick question. There's a lot of, certainly has been in Alberta in health systems over the past number of whiles, is the concept of disruptive innovation.
Yeah.
And the fact of, I think often decision makers are challenged with a system which is often highly resistant to change. What are the benefits of evolution or revolution to sometimes in terms of getting past a particular logjam to move forward and change? And so there is that incrementalism, but sometimes incrementalism needs a bit more of a external push, which might cause some damage.
Yeah.
But it's just that question of sometimes one can create theses of complexity which are, to some people, simply resistance to change.
Yeah. Well, so there are three quite different phenomena at work there. So let's start with disruptive innovation. I think it's true that there are innovations that are profoundly disruptive. And they disrupt their existing ecosystem. Amazon has eliminated the independent bookshop across Europe. And it's on its way to eliminating many different independent retailers. And you kind of think Amazon is a fantastically innovative, disruptive enterprise. If you work for Amazon, you are in one of the most traditional and conservative organizations that ever existed. You know, you are rigidly controlled. You know, so there are different kinds of disruption. There's external disruption of a marketplace, and there's internal disruption of behaviors. And my observation is that organizations that disrupt marketplaces are actually very conservative in their behavior within themselves. You know. The question about resistance is, I think, a really interesting and complicated one. And Trish Greenhalgh in the UK has done some really interesting work about resistance. And certainly I think she and I share, because we've both done lots of work about e-health systems and telecare and telemedicine, what the people who have strategic intentions often call resistance is actually the people who are doing everyday practices. They're calling it, this thing doesn't work. And it doesn't work the way we want it to. A great example, a fantastic piece of telemedicine back in the 1990s, when there was no Skype, when there was no really much of an internet. And we evaluated a telepsychiatry service in which people used video phones. I don't know, does anybody here remember video phones? Tiny little phones with like a little LCD screen, you know? We had two, they cost £11,000 each, so that's about $30,000 each. We had to put a special phone line in so that we could use them, and that was another £15,000. So this was like the most expensive way of doing 25 consults in the history of the world, just in terms of its intervention cost. Because actually, in the end, nobody really wanted to do it. And the reason that they didn't want to do it was because it didn't work for them. And it didn't work for them in two ways. First of all, actually, if you've ever tried to have a conversation with somebody using a 2 centimetre wide or 2 centimetre square LCD screen, then you will know that that demands a kind of interactional skill that most humans don't possess. Let's think about 1998 and what the chips were like then. So if two people spoke at once, the screen froze for 30 seconds because there was no bandwidth. So obviously, when people didn't want to use that, it was characterized as resistance to change. But actually it wasn't. The thing just didn't work for them. And not just that, the psychiatrists began to say, well, actually, we don't want to see people when they've just been diagnosed because they're in a state of distress and they're learning to live with something. We want to see them when they've had an opportunity to bed it in a bit and have a conversation about it rather than at a point where their symptoms are very florid. Now, that may be a good or a bad way to think about mental health problems. I'm not going to make a judgment about that, but it was the way that they thought about it. And it was a great moment with a psychiatrist who said, the problem with this system is I have to listen to patients. And the interpretation that I put on that was that what she meant was she could not control and shape the conversation in a way that worked for her. It wasn't that she didn't want to hear what patients had to say, but she had a set of very clear ideas about relevance and what she needed to know in the very compressed time and space that she had for this one patient. So resistance there was about actually the thing not being workable and not being something that could be integrated in their model of practice. So resistance, sometimes people do resist things. I'm not saying that there's no such thing as resistance, but it's important to understand that there are definitions of resistance. There's recalcitrants, people who just don't want to do it and are going to behave badly. Well, there are those people like that in every organisation. You work in a university, you're going to come across some of them. And but by and large, most people want to get through the work and they want to deliver a good service. And the question that they're asking is, does this thing do what we want it to do? And can we make it behave in a way that enables us to integrate it into the rest of the workflow? Because people aren't just doing the thing, they're doing lots of other things. Does that work for you?
Yeah, that was good. I can think of a couple of questions. I might as well continue. One is there's a big emphasis around patient-centeredness and patient preferences. And the systems actually seems to have been moved much more from one in which you identify what a patient needs based on particular clinical judgment, and now having to incorporate actual preferences, even if they don't necessarily match with clinical judgment. But I'm wondering about the whole concept of patient preferences and choice being incorporated into the system and how that affects how one might frame implementation science, which mostly came from experts and research findings being implemented on the system. But how does one deal with the concept of choice and patient preferences into implementation science?
Okay, so I guess that there are two ways to think about this. One is actually the implementation of decision-making tools. And some of the work that we've done about that. In fact, the theoretical models that I'm talking about actually came, the moment of inception was doing a study of a decision-making tool for people with atrial fibrillation to decide whether they were going to take blood thinners or not. And it was very clear that this was a complex problem of workability. And the two guys who could really use this tool, we did this in Newcastle upon Tyne, were two people who had spent their whole lives betting on horses. And they had no problem with the concept of odds. In fact, it might have been genetically encoded within them. But everybody else just, they have no, and actually I've got a PhD and I looked at this thing and I thought, what does it mean? How am I going to make sense of this? So there's a whole load of stuff about thinking about how people make sense of information and how they make sense of interactions in which they make a decision. And Glyn Elwyn and I and Tim Rapley and others developed a model of what we called kind of deliberative collaboration around this, to sort of think about how you would implement decision-making processes in different clinical contexts. Preferences, I've been involved in studies in preferences where all the preferences are actually pre-scheduled by the clinicians, So the patients are likely to prefer this, this, and this, or that, because these are the things that are available, not because these are the things that they want. And I hinted at this earlier on. A couple of years ago, I was the victim of a medical accident, and one of the things that followed that very dramatic and nearly fatal encounter with a drug was that a lot of people asked me what my preferences were. And the first preference they invited me to think through was whether I wanted CPR or not. Well, actually, let's think about that as a preference. That's not a preference in my book, That's much more existential than just having a preference. But it was framed because it was part of a treatment escalation plan that I had been involved in one of those twists of fate in evaluating. So I actually knew where that conversation was coming from. So when we invite people to consider their preferences, we invariably do so in the healthcare sector from a position of strength, because we are organising what the possibilities are for them to prefer.
Okay, and just this question that I had gotten from someone who was listening kind of online. What's the biggest challenge for implementation science today and in 5 years? And that was just, I looked at it and I went, oh my goodness. But I don't know if I just leave that to you to what frame might be the
biggest challenge, I think, is, I don't know that I could say that there is one big challenge. There are several really big challenges. And so one of them is solving either methodologically or theoretically the question individual behavior change or change management in a way that allows us to not be in an either-or position. So I think that's an underlying conceptual challenge. The other big challenge, I think, is developing a set of rigorous methods to track implementation processes and to predict their outcomes. And I think that's the kind of, that strikes me as being the kind of holy grail of implementation science, is actually being able to say, well, this is what's going to happen. Now, I've already suggested all kinds of reasons why that's perhaps a hope that we might never see realised. But I do think that is a challenge, actually understanding those dynamics and thinking about their consequences is a real issue. In 5 years' time, I think those challenges will still exist. I don't see those problems being solved that quickly. But I tell you, the other thing that's really important is there is a whole kind of program of work in many countries and in many institutions to produce a new profession of implementation scientist. And there are master's degrees that do this. There are doctoral programs appearing. There are in-service training and continuing professional development courses around doing implementation science and becoming an implementation scientist. And we have to decide what the core body of knowledge is there. And Sanjay and I were talking earlier on about how that happened in epidemiology about 30 years ago. How a gradual process of deciding what an epidemiologist was, what they should know, and how they should practice. And I think that's an important issue for implementation science. We've got the NIH definition of implementation science that I put up earlier on is actually taken from the background material for an advertisement for a job for an implementation scientist in the NIH Cancer Institute. So we have to decide what these people are and what they do and what they should know. So there's a professional issue here for the construction of a field.
Okay, are there any questions? Okay, we just, Hannah had just handed me a note because a couple of people who weren't able to attend, who are registered for the workshop, are not able to attend. So anybody who wants to attend the workshop, there are 2 spots available, and they can see Hannah just after we finish here. So we're going to be taking a break, and please join me again in thanking Dr. May for his presentation.